For years now, we've heard the compelling clinical case for hospital at home, or HAH. It's safe, effective, patients love it. That story, frankly, it's done.
Yeah, the clinical success story is pretty much established. We know it works, medically speaking.
But today, we are going completely non-clinical. This deep dive is all about what happens after that successful pilot, how you actually scale HA, how you take it from a brilliant small project into something sustainable, something integral.
Right, a cornerstone of healthcare systems, really.
Exactly. And this isn't about medicine, it's about strategy, policy, and critically the money. It's about avoiding what some experts are calling the success trap.
And our sources today, they give us this incredible view into that exact challenge. We're drawing on what, nearly 70 years of experience in France?
70 years.
The rapid rise and maybe fall in Israel, some really data-driven implementation science from Singapore, and of course the unique policy hurdles right here in the US.
So our mission for you today is to really understand the inevitable pitfalls.
Right.
And the necessary steps you need to take to make sure HAHC isn't just like a nice line on a grant application.
Or a temporary fix.
But a structural part of the system. And to kick that off, we have to start with maybe a tough truth about organizations.
Yeah, that truth really lies in what's called the organizational life cycle model of service. Every new service, HAHC included, it follows this kind of natural history. You start with initiation, everyone's excited, agile, learning super fast.
Standard startup energy.
Pretty much. Then comes growth. You hit growing pains, sure, but the momentum, the energy, it keeps satisfaction high.
So far, so good. That sounds like where a lot of HAHC programs probably feel they are right now, aspirational.
Precisely. And that leads directly into the success trap. That's the point where you become so convinced that the growth and demand are just going to continue forever.
You take your eye off the ball.
You take your foot off the strategy pedal, exactly. You just assume you'll keep adding beds, adding services. And this leads almost inevitably to the riskiest phase of all, maturity.
Riskiest? Why? I mean, wouldn't you think success, maturity, that's the goal?
You'd think so, but no, because in maturity, growth often stops. Maybe the low-hanging fruit patients are gone, maybe people just get tired, the initial energy fades, the service reaches a point where it's just going okay.
And going okay is bad.
Going okay is lethal. Because the natural history of any service in any market is that eventually decline is coming. It's driven by external step competition, cost pressure, aggressive price wars from payers. Leaders have to expect this, plan for it, and actively intervene, sometimes pretty drastically, to prevent that fall.
Okay, that's the key insight then.
Yeah.
If you wait until the service is mature and running smoothly, you might actually be too late. You've got to plan for that potential decline while you're still succeeding.
Bingo. And we saw this life cycle play out incredibly quickly and dramatically in Israel.
Tell us about that.
Oh, it was rapid. It was driven mainly by private organizations during the pandemic, right? They used special Ministry of Health budgets, had clear guidelines, some unique flexibility too, like allowing doctors televisits for day 2 or 3.
Okay.
And this bit is crucial. Most referrals came directly from family physicians. They bypassed the ED bottleneck entirely.
Wow. Okay. That sounds like a perfectly executed growth phase then.
Yeah.
So you said they hit a hard stop. What went wrong? What was the failure mechanism?
Well, the clinical model worked like a charm. But the finance model, it basically set them up for failure. They hit that maturity challenge hard because they couldn't transition the funding. It stayed in the special Ministry of Health crisis budget.
So it wasn't mainstream permanent financing.
Exactly. It wasn't entrenched. So it became this line item that payers could negotiate down hard.
I see. Once the crisis faded.
Right. Payers realized they had leverage, started pressing the price aggressively. Then new low-price entrants came into the market, making the economics really challenging for those original, maybe higher quality providers. Growth just stopped completely. At about 6–7% of internal medicine beds being done at home. That was after maybe 4.5 years.
That's fascinating because, look, 6 to 7% adoption in under 5 years, on paper, that sounds pretty good, right?
You'd think so.
But the source material flags it as a failure because the energy, the momentum to develop new specialized HAHC services, things like surgery at home, oncology at home, it just evaporated.
It stalled out. WHAHC remained what the source called a supplier's product, not a core system strategy. It perfectly illustrates that success trap. They thought the initial volume and enthusiasm would sort of automatically solve the policy and funding problem. It didn't.
Okay, let's contrast that rapid rise and fall in Israel with, well, the chronic inertia we see in France. WHAHC started there in 1957, almost 70 years ago. And they're still facing major scaling hurdles.
It is a stunning paradox, isn't it? France actually has a national target 30 to 35 HealthH patients per day per 100,000 people. But there's this huge disparity. The public health providers make up 40% of the total number of providers.
Okay.
But they only produce 20% of the total patient days. They're just much smaller. The median size is only about 28 patients per day.
And the sources were clear that small size is basically an economic killer in this space.
Yeah.
Right? Those smaller public providers, they're often running at a deficit. They don't have enough staff.
That's right. Many have less than one full-time equivalent doctor if their census is under 30 patients a day. It leads to this kind of vicious cycle.
How so?
Well, to survive, they often focus on highly specialized care, like chemotherapy at home, which sounds good, but it results in shorter stays, maybe 20 days versus 30 for private providers. And that means lower daily revenue, making profitability even harder.
And on top of that, the hospital management often just doesn't get HealthH specifics.
Yeah, the internal support systems, think IT, pharmacy, logistics, they're often not adapted for delivering care in the home. It's geared for the mothership hospital.
So organizational inertia, not just clinical resistance, is a huge barrier.
What?
What was the French solution to try and break this sort of systemic paralysis?
So the National Agency for Performance Support, ANAP, they call it, stepped in. For listeners maybe not familiar, ANAP is basically the government agency in France tasked with boosting hospital performance and quality.
Got it. So central body pushing for change.
Exactly. They use that central authority to develop this target support program specifically for those struggling smaller public providers.
What did the program focus on?
Things like strategic planning, understanding their local territory, getting the budget balanced, and critically, creating faster, smoother admission processes.
And did it work?
The results were pretty immediate, actually. About 76% of the providers who participated implemented these strategic action plans. And those providers saw their patient numbers jump by 10 to 20%.
Wow, compared to the national average.
Which was only growing at about 6%, so yes, significantly higher. It showed that intentional, centralized strategy could actually overcome decades of that organizational inertia.
But there's still a lingering policy barrier, isn't there? Something that ties back to our final thoughts.
Yes, patients in France currently cannot request HAH themselves. It has to be initiated by the physician or hospital.
Which limits growth, limits public awareness. It proves that even after 70 years, political and cultural barriers can persist.
That's the culture change hurdle. It's a big one.
Okay, now let's pivot from policy inertia to data science. Let's go to Singapore, where they seem to have treated scaling not just as, a hopeful exercise, but as a measurable, research-backed implementation strategy.
That's right. The NUHS at Home program there, it started as this tiny 6-bed non-COVID pilot, scaled up pretty quickly to 75 beds. But they recognized early on they needed actual evidence on how to scale effectively, not just opinion pieces saying they should.
Yeah, I found that fascinating how they embedded their growth plan within standardized research protocols. They explicitly used established implementation science models, right? Like EPIs for context, ERIC for strategies, REAIM for outcomes.
I know, it sounds maybe a bit academic, like jargon.
A little bit.
But for you, the listener, it's actually critical. These are basically just standardized ways to measure 3 key things. Is the environment actually ready for this change? That's context. What specific steps are we taking to make it happen? Strategies. And are we actually reaching the right people and helping them? Outcomes. It turns scaling into, well, a science.
They also use something called Barker's phases of scale-up. What's that about?
It basically recognizes that scaling isn't one size fits all. What works to get you from, say, 6 beds to 25 beds is totally different from what you need to get from 50 to 100 beds. Your strategy has to adapt as you grow.
So what did that look like in practice?
Well, their phase 1 was all about building the basic infrastructure. But phase 2 shifted focus heavily onto clinician training, support, agile strategies. They even introduced things like an LLM-based chatbot to help clinicians quickly access protocols out in the field.
Okay, the implementation science sounds really solid. But how effective was the scaling itself? Did they hit their targets?
Well, their utilization or reach, it kind of stabilized around 1.5 to 2% of total acute hospital admissions, which frankly is still quite far short of their management goal. They're aiming for 10% by 2030.
Okay.
But their data revealed this really massive efficiency nuance, something really important.
Okay, tell me more about that nuance.
So the average length of stay for a patient admitted directly to WHAHC was about 5 to 6 days. Pretty efficient.
Right.
However, patients who were transferred from a regular acute ward into WHAHC, Their total length of stay, ward time plus hergia time, was actually 8 to 9 days.
Wait a minute, 8 to 9 days? That's longer.
It's 2 to 3 days longer than the average acute admission length of stay in their traditional hospital.
Hold on. If WHAHC is supposed to be a tool for efficiency, right? Reduce length of stay, free up beds. But this data suggests using it as a transition bed actually increases the total time a patient is under acute care. Doesn't that kind of threaten the whole business case?
It raises a massive red flag, doesn't it? It really zeroes in on that critical question of patient selection. If you wait until the patient has already landed on the acute ward, spend a few days there, then move them to WHAHC, you might actually be introducing inefficiency into the system.
So the goal has to be diversion, not just transition.
Exactly. As we saw hinted at in Israel, the ideal is to divert patients directly from the emergency department, or even better, from primary care, straight into WHAHC. The Singapore data is a stark warning. WHAHC needs to be used for true acute diversion to realize its efficiency potential, not just as a fancy step-down unit.
That's a perfect segue to the U.S. experience, where the growth path has been almost entirely driven by that acute hospital care at home waiver that CMS put out in late 2020.
Right. That waiver was the game changer here. It unlocked critical funding by allowing providers to bill Medicare for WHAHC services, crucially for direct admissions.
But despite that huge policy lift, the gap between, let's say, ambition and reality seems pretty stark here, too. You mentioned nearly 400 hospitals applied for the waiver.
Yeah, nearly 400, yet best estimates suggest maybe only a dozen, perhaps fewer, have managed to reach a daily census consistently over 25 patients. The operational and strategic barriers in the U.S. market are proving massive.
And the mission, as pushed by some of the big, ambitious health systems, is definitely scale. They want to handle the growing number of patients with multiple chronic conditions and ultimately make WHAHC the default model of care, not the exception.
They want to be too big to fail, essentially. You hear systems like Atrium Health talking about aiming for 400 ABH beds in just one market. That's huge scale.
So what's holding them back? What are the specific U.S. barriers?
Well, some are policy-related, still quite restrictive eligibility criteria, specific diagnosis limitations in the waiver itself. Others are operational, dependence on really labor-intensive manual processes to even identify eligible patients.
Like nurses scrubbing charts by hand.
Often, yes. And then there's the logistical complexity, sometimes chaos, of coordinating care when you rely on multiple different third-party vendors for nursing, pharmacy, DME, etc.
And the biggest threat, looping back to Israel, is policy stability, right? That CMS waiver, it's still temporary. It's not permanent legislation.
Exactly. It has to be renewed. And given what happened in Israel when the special funding dried up, you'd think U.S. providers would be laser-focused on making this permanent.
So why the delay? Why isn't the lobbying intense?
Well, part of it is also the state-level complexity. Even with the Medicare waiver, restrictive state rules mean only about 10 out of 50 states currently cover WHAHC under Medicaid.
So that leaves out huge numbers of vulnerable patients who could really benefit.
Precisely. And that's why the data from MassHealth, the Massachusetts Medicaid program, is so incredibly important.
That analysis provided the crucial proof point for equity, didn't it?
Yes. It confirmed WHAHC is safe, effective, and accessible for traditionally marginalized populations. Their WHAHC cohort was much more diverse than national data, 40% Hispanic members, 62% non-English speaking, really high clinical risk and social deprivation scores. It's solid evidence that the model can be equitable.
And financially.
Yeah.
Does it prove the model works for that population too?
It did. The mean costs were around $11,000 per episode, which they found was comparable to traditional brick-and-mortar hospital costs for similar Medicaid patients. That's the kind of financial proof you need to argue for permanent legislative coverage, both state and federal.
Okay, so bringing all these global experiences together, France, Israel, Singapore, the U.S., what's the core lesson here?
I think the core lesson is unambiguous. Sustaining hospital-at-home programs, making them stick, it's fundamentally about organizational alignment, clear strategy, and political will. It's almost never just about the clinical protocols anymore.
We've definitely seen that critical size seems necessary for financial viability. Look at the struggles of those small bulk providers in France, or the generally limited scale so far in the U.S. You just can't seem to run a profitable acute service on, say, 28 patients a day.
Right. And intentional alignment, making WHAHC part of the entire health system's core strategy, seems essential for getting that long-term buy-in and support.
And the Israeli experience is that stark warning. Financing must transition from some special temporary budget to become a permanent mainstream fixture. Otherwise, it won't survive that maturity phase when payers inevitably start squeezing prices.
Absolutely. The future vision is still huge, though. Experts talk about 10% to 20% of all acute beds potentially moving to NCA-H. Some even suggest up to 45% if you start including specialized care like psychiatry, rehab.
But if we achieve that kind of scale, we have to come back to that utilization question you raised from the Singapore data. How do systems stop AKAs from just becoming more beds, potentially expanding overall acute capacity, and maybe even driving unnecessary admissions?
Yeah, that's the million-dollar question, isn't it? The answer has to lie in rigorous, system-wide measurement. Using metrics like the average number of clinical visits per patient per day, something Singapore tracked, if that number starts dropping too low.
It suggests the patients aren't really acutely ill enough for that level of care.
Exactly. It suggests the program might be admitting patients who don't truly require that intensity, which ultimately undermines the entire model's value proposition. You have to maintain that acuity focus.
Okay, so after digging into all this, you, our listener, should now have a much richer framework. Not just for understanding if hospital home works clinically, we know it does, but how it survives.
Yeah.
How it navigates those inevitable challenges of competition, budget cuts, organizational growing pains.
To remember this key takeaway, if nothing else, the barriers to scaling HAH. They're rarely clinical anymore. They're almost always financial, political, and cultural. That success trap is very real, and you absolutely have to plan for it way in advance.
So thinking across all these global programs, maybe the biggest hurdle, the final frontier, is shifting HEH from being this sort of special program, something that needs waivers, constant legislative lobbying, maybe pre-authorization for every single patient.
Right, moving it away from being an exception.
And turning it into a true, reliable standard of care, something patients can actually understand, actively request, and count on being there. If HEH adoption is always tied to, say, avoiding building a new hospital wing or leaning on temporary emergency budgets, can it ever really fulfill its potential?
That's the question.
So you have to consider, what will it really take to make hospital home too big to fail in your healthcare market?